Hello, I think we should make a start. Welcome to UCL's Lunch Hour Lectures. My name is James Neal. I'm the host for today's lecture. Apologies, as I said, for some of you who may have come here for a differently themed lecture. That's one of those things that happens when you print the booklet a long time ahead, and unfortunately it's difficult sometimes to clarify that. But more importantly, we have a fantastic lecture ahead of you. I'd like to introduce Dr. Claudia Cooper from UCL Psychiatry. She's been working at UCL on this research theme for about 14 years, and she is also a psychiatrist with the NHS, and I'm sure what she has to say will be of great interest to all of you. Thank you, Claudia.
Hello, thank you for coming. Yes, I'm going to talk to you today about elder abuse, which is a topic that has been fascinating me and the people I work with for the last 12 years. And I'm going to try and explain to you in the next half an hour what it is that we have found out and what we find so interesting about this topic. The topic essentially of how humans behave to each other, and specifically how people behave well and less well when caring and looking after older people. So the first thing to say about abuse is it's been variously defined, but fundamentally it's when somebody's human or civil rights are violated. And there's nothing fundamentally different about the fact that it's elder abuse. Any group in society who are vulnerable, or any situation in which there's a power differential, fundamentally, some people can in certain circumstances be prone to abuse. And we've been talking for longest, I suppose, about child abuse. And in about 1975, somebody published the first scientific paper on elder abuse called granny battering. Well, that's not a term that we would use now, but that really started off the modern period of research on elder abuse. And people with learning disabilities or who are vulnerable for other reasons in society can also be prone to abuse. So whether that's intimate partner violence, as it's called, abuse within relationships, or sometimes even abuse in the workplace. Anywhere where there's a power differential, abuse can come. So I thought I would highlight today 10 things that I think are interesting about the subject of elder abuse. So 10 take-home messages. So the first one would be just that abuse is abuse. There's nothing inherently different about the processes and the systems depending on who it is that is abused. So what do we mean when we talk about elder abuse? Well, there are different sorts of abuse, and perhaps the most common is called verbal or psychological abuse. And this is often seen, it's the most common type of abuse, for example, that family carers of people with dementia report. So when you're caring for someone for long hours and you might occasionally find yourself screaming and shouting, or sometimes people talk about ignoring somebody rather than meeting their needs. That is psychological or verbal abuse. I've used a few quotes to try and illustrate this from a study we did where we went to care homes. I remember it was in the middle of the Summer Olympics in 2012, and we went round all care homes talking to people, talking to care workers in those homes about the sorts of care that they gave and when care was good and went well, and also when care went badly. And we said to them, are there times when you feel the care you give are abusive? And they spoke to us honestly about that. And here are some of the things that they said. So somebody talking about ignoring somebody that was asking for care said it's not to do with people being deliberately nasty, it's just you actually don't have the brain capacity to assess all three things at the same time, so one person's going to get fobbed off. So this is a care worker describing how they had three things to do at once, and so they ignored one thing. And that brings us to what I think is one of the second take-home points, which is that abuse is actually the name of the behaviour. When you talk about abuse or an abuser, there's a tendency to think of the most severe cases and of the abuser being somebody that's being deliberately nasty and should be blamed and shunned rather than helped. But actually, abuse is inherently defined as a behaviour. Intent is something that our legal system defined. So whether or not you deliberately meant to be abusive is something that is decided in a court of law sometimes. And blame, whether or not you should really be to blame for doing that, is something that society determines. The other type of abuse, which is some of the most serious types of abuse, is physical abuse. This reminds me of a case recently in a care home. I went to see this lady, and she was in a wheelchair, and she was strapped in, very much like that man is. And she said, "This seatbelt is very uncomfortable." So we undid it. And I mentioned it to the carer, and she said, "Oh, we just use it to transport her." And then I thought I'd go and say goodbye to this lady in the lounge, because I was a little bit worried about her. So I went to say goodbye, and there she was, and she had the seatbelt done up again. So I went and said something to the carers, and it turned out that actually she had that seatbelt on for quite a lot of the time, and the carer said she needs it, otherwise she will fall. And often this is a situation that we're in clinically, where people say, well, I have to do that because this would be worse. And the answer in many different situations is generally, but that's unacceptable. So we need to think of a way to manage this situation where that person's human rights and right not to be strapped in a wheelchair can be respected, but that also they don't fall on the floor. And that can be a common situation, that people do things because they feel they have no choices. And part of what we have to do as a clinical service is to open it up and say, well, this can't be right. So what are the choices and what should be done? There's a picture there of some tablets. There's been quite a lot talked about recently about chemical restraint and the use of antipsychotics and sedatives, particularly in people with dementia, solely for the purpose of controlling behaviour and sedating, and the fact that that is wrong. And there's been a real move in dementia prescribing not to use these sedative and antipsychotic drugs that can cause harm. And that's been a success story in old age psychiatry recently. If you look at the graphs of prescribing over the last 5 to 10 years, they go down. Certainly between 2010 and 2015, we've been prescribing less of these drugs, and hopefully that's because we've been thinking about other ways of managing behaviour. Right. I say another sort of abuse, but we tend to talk about abuse and neglect, suggesting that it's seen as a little bit different. But neglect is common. This is an example that the carers talked to us about. Some carers will give them 2 spoons and the food will be chucked. So that feeling that if somebody's not able to say how much food they want for lunch, that a stressed or busy carer might stop feeding them before they'd had enough to eat. And neglect can be all sorts of things. Neglect can be not giving anybody any form of social stimulation, leaving people in their rooms for long hours, making them wait too long for care, all sorts of things like that. And here are some other types of abuse. Financial abuse is all too common and can be is a bit different really to other forms of abuse. Whereas physical and verbal and psychological abuse in dementia certainly often come from the stressed carer who's at the end of their tether. Of course, financial abuse isn't really an acceptable end result of feeling stressed at the end of your tether. It tends to be something different, but something that is common. Institutional abuse is where people are following the ways of the institution, and consequently individual rights are not considered. There's a video of a real situation that was covert filmed that's on, I think it's the one of the elder abuse charities shows, where a man has soiled himself and is asking to be changed, and there's a carer saying to the other carer, no changing during meal times. He knows that, we all know that, no, we don't do that. And so a feeling that there's a rule that might have been there for reasonable reason, that you don't want to start changing incontinence pads in the middle of dinner, but that actually the result of that in that situation is that clearly that person is being in a neglectful situation, because nobody wants to eat their lunch while sitting in a dirty incontinence pad. So why does abuse happen? Of course, one has to be careful when talking about this, not to sound like we're saying, well, this is inevitable, or abuse is acceptable because this is why it happens, but there do seem to be certain situations in which it is more common. And coming back to what I said at the beginning, fundamentally this is a power imbalance, and there's generally a perpetrator and a victim. And certainly the reasons that older people are often more vulnerable to abuse, dementia is a very common one. I've put challenging behaviour there. I was pulled up the other day by one of the research network volunteers from the Alzheimer's Society who said the term distressed behaviour was better because challenging does not take account of the fact that people with dementia behave in certain ways because they are distressed. But dependency, vulnerability and dementia all mean that people may be at risk of abuse if in situations where that might occur. And the perpetrator as well, some people are more inclined, perhaps due to personality or mental illness, to behave abusively in certain situations. And carer stress can often be a big part of the end reason this happens. The relationship between the perpetrator and the victim is important, and I could give you many examples of this, but certainly one we've been thinking about recently in care homes is about why abuse might be very common in that setting. And certainly we've been thinking about whether that's something about the personhood of people with dementia. In other words, if you are caring for somebody with dementia who you have known for 50 years, you know that person. You know them from when they were young. You see them then as a person who's developed dementia. But if you are a care worker and the person arrives with severe dementia, can you still see the person? Do you still understand them as the person they are? And if you as a care worker start to depersonalize that human being and not respect them as a human, perhaps abuse might be more common. The other thing, the reason I've put time and quality for relationships is that certainly there has been some research showing that in countries such as South Korea, when they looked at who is most likely to abuse, it was daughter-in-laws, whereas in the UK it was spouses. Now it seems pretty clear that that's not about the fact that spouses in the UK are that we're inherently more abusive or that daughter-in-laws are more abusive in other countries. It's about where people with the most severe needs with dementia are looked after and who by. And certainly, whereas most people in the UK with dementia are often cared for by a spouse, daughter-in-laws tend to have more of a role of caring in some countries. And certainly the society and the environment and the legal environment in which a situation is operating affects how likely abuse is to happen and how likely it is to be detected. There was a case in a hospital not so far away where a large amount of abuse that had gone undetected for a long time was actually reported not by the doctors, not by the relatives, not by the nurses, but by the window cleaner. And I think that's a really powerful example of how sometimes it takes people looking in on a situation to see it for what it is. And the more that a society or an institution is open and has people coming in, and if you're a care home, having volunteers and lots of people coming in to give new perspectives on a situation, the less possible it is for abuse to flourish. So this is a rare celestial event, and this is how in the NHS, where I work for some of my time, abuse can sometimes be seen. That normally we see no evil, hear no evil, speak no evil, but just sometimes there is a case of elder abuse. And certainly the research we have done has shown that actually it's much more of a spectrum, that abusive behaviour is behaviour and all behaviour tends to exist on a spectrum, whether it's a good or bad, that many people will react in abusive ways sometimes, but very, very severe abuse is less common. The research that we've done on how common abuse is, obviously that's a difficult question because you have to ask yourself, what is abuse? We know what abusive behaviour is, but where do you put your cut point? What do you decide is an abuse case? But it seems that certainly in the older general population, about 5% of people report that they have experienced some abusive behaviour. And as you move up into more vulnerable populations, that increases until when people have asked nursing home staff whether or not they've observed others abusing, 80% say they have. And so this is my third point, that the prevalence of abuse tends to mirror where people with more severe dementia are. This is what we found when we asked family carers of people with dementia about a range of different types of abusive behaviour that were likely to be happening more commonly. And as you can see, many carers talked about how they'd sometimes in the last few months screamed or yelled at the person they were looking after, or used a harsh tone of voice, or insulted or sworn. And overall, a third of family carers of people with dementia had reported some abusive behaviour at least sometimes. And certainly when this study came out in 2009, it was quite widely reported, and in the media they used the higher figure, which was that 50% of family carers had reported any abuse happening at any time. And certainly the way that that was received by patients' groups was very positive, which is, you know, we need to acknowledge that this happens, and we need to acknowledge that it's common. And people need to be able to talk about these things, because if you don't talk about it, if you don't ask, then people don't feel able to tell you, and they don't feel able to get help. My fifth interesting fact, or that I think is interesting about abuse, is that people don't tend to agree on what it is. And over the last 10 years, we've developed a vignette about a woman who's got dementia and who is cared for by her son. And we've been asking people in lots of different countries, lots of different groups, which ways that Tom, her son, can look after her might be seen as abusive. And here are just some of the results from the study we did in the UK and one we did in Romania. And if you just look at the third line down, just as an example, we said, is it okay if Tom were to lock her in the house all day while he goes out to work? And as you can see, at best, 63% of UK professionals thought that that was abusive, and 23% of carers in Romania thought it was abusive. So really, there isn't much agreement on what abuse is. And certainly, by any definition, depriving somebody of the ability to leave a building, and therefore really putting them at risk if there was a fire, for example, and possibly putting them in a situation that might be quite frightening, it's quite surprising that a third of UK professionals don't view that as abuse. And I think it shows that it's something that we need to be talking and thinking about a little bit more. One of the things when we're managing situations of abuse in the NHS and clinically is that it can be a balance. So you've detected the abuse and you're thinking about how to manage a situation. And of course, everybody has a right to live without abuse. But everybody also has a right, if they have capacity, to decide how they want to live their life. So sometimes things aren't as simple as rescuing people from abusive situations. A lot of people don't want to be rescued. They want to stay living in that situation, and they'd like things to be different. There's a case I was aware of a few years ago of a couple where there'd been lifelong domestic violence, and this lady who had developed dementia had decided over a very long period of time to stay in this relationship. And there was a lot of debate and disagreement amongst the team because she now had dementia and perhaps wasn't able to make that decision for herself. And many people felt that she should not be put in an abusive situation that she couldn't agree to, but there was also a feeling that this was something that she had wanted for years, and being taken away from her husband would be a real loss. So it can be difficult to manage those situations. So that's my sixth comment on abuse, is that people with mental capacity to do so may refuse help to stop abuse. And I think a sensible approach to that is to be clear that if people refuse that help, then that may be something that they have capacity to do at that time. But that doesn't mean that you might not be able to mitigate the risks, and that doesn't mean that you wouldn't try and stay involved in some way or try and stay in contact to help that person in any way that they find acceptable. So how is abuse managed? Well, in reality, the great majority of the situations we've talked about with carers screaming and shouting would never be defined as an abuse case. And even more severe abuse is mainly not detected or reported. The most severe cases in this country would be reported to safeguarding services, and then they would have an investigation, and in some cases would decide on no action, or they may give increased care. They may decide that somebody can no longer live at home, or in very severe cases it may be reported to the police. Why is most elder abuse never detected? Well, inherently this is often something that victims of abuse don't want to talk about, and often that carers feel they cannot talk about. Probably paid staff in care homes are least likely to report abuse that might obviously lead to them losing their job and their income. So my seventh thought is that most abuse is undetected and unreported. But one thing that we have shown, I've got the reference at the bottom of the page, is we did a study in which, with some junior doctors who were coming in to work in psychiatry, as part of their induction, they were given a talk about elder abuse, and they were told about what it was and how to detect it and what to do. And what we found is that certainly on paper their knowledge of what abuse was and their ability to detect it using our vignette increased greatly. And when we stayed in touch with them 3 months later, they were more likely to report having identified a case of abuse than those that had the control condition that hadn't had this training. So it makes sense that if you tell people about abuse and you tell them how to report it, they will be more likely to. How do we find out about abuse in care homes? Well, we're just coming to the end now of a study in which we have been asking care workers in 91 care home units in the UK to anonymously report abuse. Because certainly, as I've said, in situations where people are paid to work as carers, they're unlikely to report it if not allowed to do it anonymously. And there are some ethical issues with that, with going into care homes and asking the care workers whether or not they've behaved abusively, but not being able to directly address that abuse when you find out about it. So what we have done is we have agreed with the ethics committee that we will tell the home that there is some abuse going on in that home if more severe abuse is reported, so that they know that this has come forward, although they won't know the specifics of who reported it. So we're about to report on those results soon. That's the MARC study. There's lots of the MARC team here today, and the results will be coming through soon, but certainly what it has shown is that neglect and abusive acts, and particularly neglect, are certainly not uncommon in care homes. So coming back to this original slide about what are the situations in which abuse tends to happen, I wanted to end by thinking about how we might reduce and prevent abuse. There was a good review recently by Ayalon et al., by a group who looked at all the studies that have tried to reduce elder abuse. And one of the interesting things that comes out of that is the best evidence really is for reducing the use of physical restraints in care homes. So you remember that slide where somebody had a seatbelt on in a wheelchair, or sometimes when people are restrained to beds. And there are countries in which that is legal in some circumstances, in the Netherlands and Germany, for example. In the UK, we have a tradition in which that is not, or we have a legal situation in which that is not permitted under any circumstances. But how you manage severely agitated and aggressive behaviour in dementia is something that's been responded to differently in different countries. So where those restraints are allowed under some circumstances, there's something that can be measured, and so they've been able to look at what reduces them. And certainly when you educate staff to do something called person-centred care, which is where care isn't given on an institutional level, where you sort of think about everybody's going to have lunch at 12 o'clock because that's lunchtime, but you really think about what that person needs, what they want to do, and start with the person that you're caring for and try to design the care around them. And when you do that and you think about that person and you think about their life history and you centre your care around them, then abuse tends to happen less. So that may give us some clues as to what might reduce other forms of abuse which are harder to detect. It makes sense that if you see someone as a human and you treat them with respect and dignity and you have the resources to do that, that's not an environment in which abuse would flourish. So generally, when thinking about reducing and preventing abuse, we're thinking about creating an atmosphere of openness in which people, not just window cleaners, but everybody can see in and see what's happening. We're thinking of protecting victims and supporting them, and where the abuse might be a reaction, for example, to very agitated behaviour, is there anything we can do to reduce that? And also, I talk about a power imbalance, but how much can we empower victims to talk about when abuse is happening and to help in the fight to not make this something that is accepted. The legal situation having rights, there is now a law specifically against elder abuse. And in the perpetrators, where this is a result of stressing caring, how can we reduce the stress of carers and how can we increase the skills? So a common thing that we find in care homes is people that say, well, we have to force him sometimes to have a bath because the only alternative is not to be clean. In the same way, if we have to put a seatbelt on because the only alternative is that this person falls on the floor. And it's about educating people and thinking about how to make alternatives to that. So how might it be that somebody could be kept clean and managed with dignity to have a bath rather than being forced? And that's about increasing skills and increasing support as well. Where there is strong management, certainly abuse in care homes and neglect are less likely. We've just finished a trial, the START family carer trial, which we've just run, showed good ways to help to reduce anxiety and depression in family carers by giving them skills and looking at the ways that they coped with the issues of caring for someone with dementia. What we did find is that intervention didn't actually reduce abuse. And that, actually what happened was that abuse went down in the intervention group, but it also went down in the control group. And I think that said something about how we, the difficulties really of researching abuse, because when the researchers came to us and told us that they had found examples of abuse in either the control or the intervention group, we had a moral duty to do something about that. And so it can be difficult sometimes in a clinical situation to research a treatment for abuse, because inherently by asking about abuse, you're intervening in the control group. So here is my summary of my 10 points, which I think are interesting about elder abuse. So there's nothing specifically different to other sorts of abuse. It's a behaviour. Where severe dementia is common in society, abuse tends to be more common as well. A third of family carers report abuse. Not that people can always agree on what abuse is. We can try to reduce and stop abuse, but if people have capacity, they might refuse that help. Most abuse is undetected and unreported, but we know that by teaching professionals about it and how to report it, we can help that. We probably need some anonymous reporting to reduce abuse in settings where professional carers are abusing. Because in care homes, abuse and neglect are not uncommon. And the best evidence we have at the moment is for staff education and person-centred care for reducing abuse. Thank you. Oh, and can I say thank you as well to everybody from the Division of Psychiatry, particularly the people that have come today, and to Jill Livingston, who's done all of this research with me, and to our research funders. Thank you.
Thank you, Dr. Cooper. We have time for some questions, because you kept that to time very nicely. We have microphones around the room if people want to use them. So do we have any questions here? Can I ask a question? Can I ask something about the partners that you work with? You mentioned some of the charities that you have worked with. How has this work been received in terms of what might be done by other groups? In other words, what kinds of pressure can they put on people? What sorts of things have people learned? How is it making a difference? I mean, it's clearly full of very interesting and important conclusions?
Well, this is, I mean, certainly there's even a charity action on elder abuse specifically for this issue. Certainly, the Alzheimer's Society has been very interested. I have to say, when we were issuing a press release and it was widely taken up saying that half of family carers had reported acting abusively, I can't admit to not being slightly trepidatious. But the Alzheimer's Society were extremely supportive, as were the family carers. And I think it was a while ago now, but I was on GMTV and I think they came on with, and we had a discussion and they had a phone in. And everybody really wanted to talk about this. And I think that, you know, if you are caring for somebody with dementia and you are one of the third of people who admit to behaving abusively, I think it must be really awful to feel that you are completely alone and to not only manage the stress of caring, but also feel that you've got nowhere to turn for help and you're stressed and you don't know what to do and perhaps you feel guilty. And actually being able to find out that this is happening to other people and get help that you need must be a great relief. So yes, we've been generally very supported by the Alzheimer's Society in this work we've been doing.
Thank you. We have a number of questions here. So firstly over there, I think, and then second over here.
Hi, I just wanted to know, have you done any research on dementia in developing countries?
I did actually. We went to India and we did a seminar on elder abuse, and we had a very interesting discussion. And certainly elder abuse research there's not been very much in developing countries. It was a very powerful discussion. And one of the things that actually happened at the beginning of the seminar was that everybody stood up and threatened to walk out and said, "We don't have any elder abuse in India. This is disgraceful." And somehow we got everybody sitting down again, and we had quite a good discussion. And I think that, you know, the legal and the social situation in which you're operating is obviously affects how things are managed. But certainly every country is struggling with this. And I think that it can be particularly difficult in situations where there isn't such perhaps a welfare state and support, and families really are managing on their own. And certainly I was very interested, as I've said, the abuse that we see in this country is often in care homes. But in many countries there are no care homes. So people with severe dementia are managed at home. And we did a cross-national study and found high rates of abuse in the southern European countries compared to the northern European countries. And when we reflected on that, obviously abuse is human behaviour is human behaviour. It's unlikely to be inherently different in different countries. It's about where you look after the most vulnerable people in society. And in Italy, for example, where most people with severe dementia were looked after in their own homes, the rates of abuse in the community were higher, whereas in our country, most people with severe dementia are in care homes, so we see the high rates there.
Thank you. And then a question here, I think.
Thank you. Thank you very much for your presentation. I would like to know more about interventions that could be done at a population level. I study an MSc in population health, so maybe that's why. Because I'm interested in knowing what can we do in terms of social policy to address the causes of these. And there's also a gender issue around this, because the health system doesn't collaborate or doesn't support who are family carers that are often women, and as in the same way didn't recognize historically the role of domestic work as a paid role. The same is happening with caring of people with disabilities, in this case dementia. What do you think that can be done to effectively tackle the causes of abuse?
That's an interesting question. I mean, I suppose fundamentally when you think about care homes, for example, which are, I think, a big part of the situation of where elder abuse is happening, as I've said, you have to think about how can we generate an environment here and in the community where abuse is less likely to happen. And certainly I think what we've seen is that where there is strong management and where there are adequate resources and where people have time and skills, abuse is less likely to happen. And I do think, without wishing to sort of labour the point, there's something very powerful about seeing people as people, about not just seeing the dementia. I think that most, although there are a very small minority of sadistic people in this world, I suppose, most people, if they see the humanity in somebody, they're less likely to behave in that way. And I think a lot of abuse happens because people don't see the humanity, or perhaps because they just don't know how else to respond. As I said, very often what you come up against is that people don't see that they've got other choices. And sometimes care workers who are on the front line don't know where to turn if they don't have strong management or they don't have lines of responsibility. And similarly, family carers might feel very isolated and not know where to turn. So support for family carers, support and management for care workers, and openness. It's wonderful. I was in a care home just before Christmas and I looked out the window and there were about 50 primary school children trooping in with Christmas presents. Things like that, things that bring the community into care homes, things that make them part of life. I know that they've been experimenting in other countries with coffee shops, with nurseries and older people's homes together. Anything that brings people together and prevents silos and dark places where things can happen and not be noticed is good, in my view.
Thank you. Just time for a very quick question here. Thank you.
Thanks, Claudia. That was really interesting. To what extent, there's something at play here about professionalisation, and where there's obviously people with dementia, including severe dementia, who are within health services or in transit to, even though they live in the social sector in care homes. And so the NHS is obviously highly professionalised and qualified, and then you've got what's very much thought of as an unprofessionalised sector, and where that plays in this.
Well, yes, Anne is project manager on Mark. I mean, Mark could be part of the answer, couldn't it? We hope so. I mean, we hope that through the Mark intervention, which is going into, we've got in 5 care homes at the moment, aren't we? 4. Going and regularly meeting in groups. So our researchers are going in and they are going through a manual and they are talking to care workers about what dementia is and about how to manage distressed behaviour that might happen in dementia. And also about positive things. I've been having lots of meetings this week about activities in care homes. If you go into a care home and everyone is just sitting around a table with nothing on it and there's nothing to do, that just doesn't feel like an atmosphere where good things are going to happen. People need activities. And they need pleasure in life and they need pleasant events. And lack of abuse can't happen in a vacuum, in a way. You have to have good things and happiness and things that we value in life, and positivity, and then I think abuse is less likely to happen. So hopefully Mark will help that. Fingers crossed.
Thank you very much. I think we're running out of time, so thank you for your questions. Thank you for coming, and can you join me in thanking Dr. Cooper again?